microphones muted. If you're using mobile devices, make sure you're not playing around on the screen as it actually draws on our screen. And if you're failing to access the registration link, you can send your email or upload your details on the chat in order to register for that day.
Okay, can everyone see my slides?
Yes, Dr. Guzha, we can see them perfectly. Let me move to your intro. So Dr. Guzha is qualified as an obstetrician gynecologist in 2011 and is a member of the RCOG and FCOG. After that, he acquired a diploma in minimal access surgery and has extensive experience in endometriosis surgery. He's board certified gynecological oncologist and holds an MPhil from the University of Cape Town. In his current capacity, he is one of the 2 lead gynecological oncology surgeons at Parengatwa Group of Hospitals. He's involved in the running of the gynae oncology services, including cervical cancer screening services, and also chairs the gynae oncology tumor board. His main areas of clinical interest are gynecological cancer screening and minimal access surgery. Endometriosis, risk factor for ovarian malignancy, is the question that Dr. Guzha's talk is focusing on this morning. You may take the virtual podium, Dr. Guzha.
Okay, thanks, Dr. Gwanzura, for the kind introduction. I think I've done a lot of endometriosis surgery, and I've done a lot of oncology surgery. But I think I would be honest to say that endometriosis surgery is way more challenging than gynecologist surgery. So I'm here going to try and attempt to answer this question whether endometriosis is a risk factor for ovarian cancer. I have no conflict of interest, and this is going to be the outline of my presentation. I'm going to kind of like define, I think Dr. Ziki has done that very well. I'm going to kind of like go through a couple of epidemiological studies. I'm going to compare endometriosis-associated ovarian cancer versus pure ovarian cancer, if I may put it that way. One slide on management, and then communication of risk to the patients, and the take back to the clinic message. So I think Dr. Ziki has done this already. Endometriosis is the presence of endometrial glands and stroma outside the uterine cavity. It's a common condition with an incidence of 10%, depending on how you define it, and the cord characteristics. The pathological diagnosis is benign, but however, I think all of us on this platform know that this disease often recurs. And what is of interest is that this disease can really metastasize. What I also find very interesting is that it might be a delay in making a diagnosis of even up to 8 years, which has been noted in some studies, especially in our setting where women complaining to chronic pelvic pain, they are labeled chronic PID and giving multiple courses of antibiotics without pausing to think about endometriosis. So Samson, in 1925, first described the association between endometriosis and ovarian cancer. This has been known for a very, very long time. And then Scott in 1953 kind of like came up with a criteria that must be met to say ovarian cancer is arising from endometriosis. This has somewhat been modified over the years, but basically what Scott said was there should be coexistence of benign and malignant tissue in the same ovary. So if you've got cancer in one ovary and endometriosis in the ovary, it doesn't quite meet the criteria. The cancer must be identified to arise from the tissue and not to be invading from another source. And the finding of tissue resembling endometrial stroma surrounding characteristic endometrial glands and the finding of old and not fresh hemorrhage. Fresh hemorrhage might just be trauma from the surgery. So the finding of old blood quite supports the diagnosis. There should also be microscopic resection, a microscopic section showing benign endometriosis contiguous with malignant epithelium. So this is what Scott described as the characteristics that we met, what pathologists must look at to say that endometriosis, ovarian cancer is arising from endometriosis. There's this study that was done looking at the association between endometriosis and ovarian cancer. It was done in Taiwan, National Health Insurance Research Database and the Registry for Catastrophic Illness Patients. It was a retrospective cohort study of 14,000 patients, carried over a period of 14 years. They looked at 240,000 women aged between the age of 20 and 51. So they included cases in which there was no histological confirmation, which were labeled recalled endometriosis. So the patient recalled, or there was some documentation in the notes of endometriosis, but no histology. And they also looked at women with tissue-proven ovarian endometriosis. So the incidence rates for epithelial ovarian cancer ranged from 1.90 in women with recalled endometriosis, but it was as high as 18.7 in women with tissue-proven ovarian endometriomas. So after adjustment for PID, infertility, Charlson comorbidity index, and age, the hazard ratios ranged from 1.90 to 18.6. So there was a strong association between the diagnosis of endometriosis and ovarian cancer, more so in patients with tissue-proven endometriosis. Then Koch et al. In 2015 tried to answer the question whether endometriosis was associated with just ovarian cancer or other cancers like endometrial cancer, breast cancer, colorectal cancer, or any other cancers. So they looked at women that were older than 20 years between 2003 to 2005, and they randomly sampled them again from the National Health Insurance Research Database in Taiwan. So the cohort included 2,300 women with endometriosis, including about 760 with poor adenomyosis. They compared them to a cohort of about 9,064 women without any diagnosis of endometriosis or adenomyosis. These women were followed up until incident cancer dropout, and that was up to 31 December 2008. So what they found was very interesting, that ovarian endometriosis group was associated with an increased risk of subsequent ovarian cancer with a hazard ratio of 4.37. What I also found interesting was that the adenomyosis group was strongly associated with both ovarian cancer with a hazard ratio of 5.50 and endometrial cancer with a hazard ratio of 5.13. They also noted an increased risk of colorectal cancer in women with adenomyosis with coexistent endometriosis at other sites, with quite a very high hazard ratio of 13.04. However, there was no statistically significant increased risk of breast or other cancers that was observed. So they noted that there was actually a very strong association between endometriosis and ovarian cancer, and adenomyosis and ovarian cancer and endometrial cancer. So what are the histological subtypes of ovarian cancer? So malignant epithelial tumors are the commonest types of ovarian cancer, making up 90% of all the cases of ovarian cancer. It's not, what we now know is that ovarian cancer is not a homogeneous disease. It's a group of diseases with different morphology and biological behavior. And 5 main types have been basically identified. But I think 2 of them, the endometrioid carcinomas, which make up 10% of endometrial cancers, and the clear cell carcinomas that make up another 10% of endometrial cancers, have been shown to be associated with endometriosis. So in this study that was done by Kuma et al., they compared endometriosis-associated ovarian cancer versus women with ovarian cancer without endometriosis. It was a retrospective study comparing 42 cases of ovarian cancer in women with endometriosis versus 184 cases of ovarian cancer without endometriosis. So the typical patient who comes with endometriosis-associated ovarian cancer is younger. They're usually in their early 50s, compared to women with ovarian cancer who normally present in their early 60s. Most women with endometriosis and ovarian cancer present with low-grade disease, 21% versus 8%. So these patients come with early-stage tumors, usually stage 1 and stage 2. I've already alluded to the fact that clear cell and endometrioid are the common histological subtypes associated with endometriosis-associated ovarian cancer, whereas mucinous tumors were more prevalent in ovarian cancer. What I found very interesting was that there was quite a huge difference in the median survival, 199 versus compared to 62 months, and also in the 5-year survival, 62% versus 51%. So it seemed that women with ovarian cancer from endometriosis fared better. After controlling for age, stage, grade, and treatment, association with endometriosis was not an independent predictor of better survival, though, in patients with ovarian cancer. I think Ziki kind of like asked me to talk to kind of like zoom a bit more into this, but unfortunately the data is not still very clear, the pathogenesis of ovarian cancer in endometriosis. So the exact mechanism of malignant transformation is still unknown, but what is known is that atypical endometriosis shares the same genetic alteration with clear cell carcinoma, and it could represent a precursor of a clear cell carcinoma. So there was this study done by Xiao in 2012, where they looked at the molecular alterations on benign ovarian endometriosis, atypical endometriosis, and clear cell carcinomas. They looked at these at BAF250A, which is a protein encoded by the ARID1A gene, which is a major tumor suppressor gene in ovarian clear cell carcinoma. They also looked at the hepatocyte nuclear factor 1B, estrogen receptor, progesterone receptors, and P53. What they found was that clear cell carcinomas, but not pure serous carcinomas, had loss of BAF250A expression, HNF upregulation, and the loss of expression of ER and PR. They also noted that atypical endometriosis and with adjacent, where there was atypical endometriosis adjacent to a clear cell carcinomas, there was loss of the BAF250A expression, 38% versus 57.7%. So this loss of expression was higher in women with clear cell compared to those with just atypical endometriosis. The same thing with HNF upregulation, 53 versus 92%, more common in clear cell carcinomas. Same as loss of ER and PR expression. What I found very interesting was that even 20% of benign ovarian endometriosis also had similar characteristics. The loss of the BAF250A expression, 33% had upregulation of the NHF1B, and 23% had loss of ER, and 50% had loss of PR expression. But however, I think the overall message was that the concurrent rate of loss of BAF250A overexpression, HNF1B upregulation, and loss of ER expression was not observed in any benign endometriosis. So the combination of those three at the same time was not common in women with benign endometriosis. But however, this was increased to about 23.1% in atypical endometriosis, and further increased to 42.3% in women with clear cell carcinomas. So what was the take-home message from this paper that was published in 2012? So actually, molecular alterations accumulate in a stepwise manner along the transformation process from benign endometriosis through atypical endometriosis to clear cell carcinoma. So this data suggests that a portion of benign ovarian endometriosis has already undergone genetic alterations that lead to aberrant protein expression, possibly conferring a high risk for malignant transformation. But I think the bottom line is what causes these genetic alterations that will then lead to ovarian cancer. I think the answer is unknown. There are a lot of theories that I will not go into, but one of the theories is that the iron that is produced in the fluid of the endometriotic cyst promotes oxidative stress, which may then cause these genetic alterations. So endometriosis is relatively common. So when should we then suspect that we are now dealing with endometriosis-associated ovarian cancer, not just endometriosis? Unfortunately, it's not an easy question to answer. Lim et al. Published two papers, one in 2010 and one in 2009, where they showed that endometriosis-associated epithelial ovarian cancer shares the same symptoms with endometriosis, including dysmenorrhea, dyspareunia, and infertility. They also showed that symptoms in endometriosis-related ovarian cancer were similar to those in endometriosis, dysmenorrhea, 31.3%, dyspareunia, and infertility. So the symptomatology is almost exactly the same. But however, the limitation is that this was a retrospective study and kind of like studies and prevent a clear delineation of when symptoms began. So in a nutshell, what is the message that you should take to the clinic? If you've got a perimenopausal woman with a diagnosis of endometriosis, if you start getting acute or subacute exacerbation of their symptoms, this might suggest endometriosis-related ovarian cancer. But this should be considered in conjunction with imaging and measuring some of those tumor markers like CA125 and HE4. What is the management of women with endometriosis-associated ovarian cancer? I've already alluded to the fact that the diagnosis is difficult to make, and at times diagnosis is only made after surgery for endometriosis. And I want to highlight that biopsy might be helpful in cases where there's suspicion prior to surgery. But however, once confirmed that a woman is endometrioid or a clear cell carcinoma arising from endometriosis, I think the standard treatment for ovarian cancer should be applied. So what is the prognosis for these women when they're diagnosed with cancer? I kind of like bring you back to the paper published by Kuma et al. In 2011. The median survival was better, 5-year survival was better, but after controlling for age, stage, grade, and treatment, association with endometriosis was not an independent predictor of better survival in ovarian cancer. So I think this is the most important slides of my presentation. So how do you communicate this risk to the patient? There was a paper that was published in 2018, which was a cohort study of 280,000 women with nearly 5 million person years of follow-up from 1981 to 2020. They compared 17,000 women with a diagnosis of endometriosis versus 80,000 women with no evidence of endometriosis at laparoscopy, compared to 160,000 women with laparoscopic sterilization and another 17,000 age-matched women from the general population. I think the take of what this paper found was that women with endometriosis get an increased risk of ovarian cancer when compared to the general population. But if you look at the hazard ratio there, it's 1.77. When they compared to women who just had laparoscopic sterilization, but no diagnosis of endometriosis, there was a similar hazard ratio of 1.75. So when you are faced with a patient in front of you in the clinic, it's very important to communicate risk, because a patient is going to read an article that the risk of endometrial cancer, ovarian cancer, when you've got endometriosis is 70% higher. And they're going to come into the office panicking that, oh, should I have my ovaries taken out? So the conclusion from this paper was that women with endometriosis have a higher chance of developing ovarian cancer in comparison with the general population in women with laparoscopic sterilization. Hazard ratio was 1.77. So we know that the background risk of developing ovarian cancer is about 1.4%. So in women then with endometriosis, the absolute risk is very low. It's less than 3%, it's about 2.4%. So I think this is the message that should be given to women when they come for consultation, that the risk of ovarian cancer is higher, but the absolute risk is not very high. So what message should we take to the clinic on Monday? I think from my endometriosis is a common condition. It is associated with ovarian endometrioid and clear cell carcinomas, and in association, but the mechanism is not very clear. There are a lot of theories, but at this moment, it's not. We are not. There is no clear mechanism that is absolutely certain. Diagnosis may be difficult to make, and acute exacerbation of symptoms in a perimenopausal woman must prompt more investigations to exclude endometriosis-associated ovarian cancer. But I think the take-home message is that the overall risk is low. I think the prognosis for these women is actually good. I think that is my last slide. Thank you very much for taking your time to listen to my presentation.
Thank you very much, Dr. Guzha, for that enlightening presentation. So there's a typical endometriosis that can potentially increase your risk of getting not only ovarian cancer, but endometrial cancer and colorectal cancer. So slightly increasing the risk for the woman with endometriosis. I'm going to open the floor for questions. Okay. So I have a hand raised by Dr. Buma. Dr. Buma, may you please go ahead? Dr. Buma, may you unmute yourself and go ahead?
Hello?
Yes, we can hear you now. Please go ahead.
Thank you. Thanks a lot, Dr. Guzha, for the wonderful presentation. Just wanted to find out from that paper, how did they define atypical endometriosis? And also the other thing is that obviously if you do a sterilization, how do you then diagnose deep endometriosis? Because obviously it's only you look at the superficial structures. Thank you.
Okay, I think thanks a lot, Dr. I think what was women it's about that some women laparoscopic sterile but deep endometriosis, but basically they would take a history, and these were women just coming for routine sterilization, and then take a history about any symptoms suspicious of endometriosis. And if they had, they would probably then would be investigated and then determine whether they deep endometriosis or not. If not, then when it's laparoscopy, then they would look and see if there were any lesions that were suspicious of laparoscopy. And if they were there, then they would report. If not, then they'll just sterilization. So to answer the question, it's possible that possibly a few women might have had deep endometriosis missed, but a lot of them had, there was a questionnaire which was symptoms of endometriosis, and there was visualization of the pelvis, and there were no endometriosis seen prior to the laparoscopic sterilization. And then coming to your question about atypical endometriosis, I think it's a kind of like histopathological diagnosis, which is usually made after excision of endometriosis, where the pathologists see some atypical or atypical cells within the endometriotic cells, and then they'll highlight it that this endometriosis doesn't look like the typical endometriosis because of the atypia. So usually get that after surgery from the pathologist.
Dr. Vuma, you answered.
Thank you. Sorry. Thank you.
So we have 5 more minutes to take questions. We are currently downloading the presentation from our next speaker. So if we have more questions or comments from the floor, we'll gladly take them. So
can I try
Dr.
and play it
Guzha,
from my side?
Sure. If you're ready to play it, you could try that.
Yeah. Okay. Let me try and play it. I've got it downloaded already.